Just one question again, what Dr. Shimbarkar sir has asked. How many of you have seen seizures personally? Just raise your hand. So almost 50% have not seen. Now I will ask another question. How many of you have seen a seizure on video? I think everyone must have seen it. So next question is, how many of you have seen pseudo seizures? So the problem is, my talk here is on Seizure Mimickers, and the issue is, you have to really know what seizure is, then only you would know what pseudo seizure is. We all know these statistics, that epilepsy is seen, or a seizure is seen in 0.5 to 1% of population. And out of this, almost 25% are not seizures. So out of every 4 patients who comes to you with seizure, one of them is not having a seizure. So you really need to know what these paroxysmal events are. So whenever patient comes to you, before this I would just add one more line. We all are taught lot many things in neurology, but remember, in private practice or in your OPD practice, you mainly see epilepsy, headache and stroke. So you have to be well versed with these 3 conditions. Then only I think your neurology is complete. But unfortunately, this is not included very well in our curriculum. So the question is whether this is a seizure or not. This paroxysmal event, you should know by having a proper history, hunting for a witness, which is very important. You should know, you should call the witness or you should talk with the witness on telephone, and as far as possible get a home video. This clinical evaluation will let you know whether you should go for an EEG or an MRI. Unfortunately, as I have said, 25% are not seizures. So if you misdiagnose, unfortunately, these patients would land up with some other treatment and not seizure treatment. And vice versa. If you don't diagnose, then this patient would land up with injuries, and this patient may have sudden death also. As Dr. Shimbarkar sir has said, clinical presentation of epilepsy is diverse. The semiology of epilepsy is different. It may start with a motor component or a non-motor phenomena like sensory, autonomic, behavioral or cognitive changes, which may not be associated with impairment of consciousness. Unfortunately, there are many other conditions which may mimic like seizures. So, in broad way, if you divide it, there are almost 36 different diagnostic or differential diagnoses for patients having epileptic seizures. If we take, since this is a department of medicine, I would concentrate more on adolescent and adult population. And if we take this population in account, then there are around 6 groups where you can divide this stroke mimics into 6 groups. It could be syncope, it could be vascular like migraine or a transient ischemic attack, it could be various types of sleep disorders, paroxysmal movement disorders, various psychiatric disorders, and then there are various miscellaneous conditions where it could be related to drug or it could be related to hypoglycemic events. So in all, you need to have a proper diagnosis of epilepsy or a seizure. The ictal similar, you may get history, interictal history where you may find some history or the, but the most important part is interictal semiology, what the patient really had during that particular episode. And this needs to be discussed in detail or asked in detail. I think this part has already been covered where the patient, you need to know about various symptoms, event onset, and what happened before, what happened after. So I am not going to talk in detail on this. But most important part is you should, whenever you are in doubt, you should always have a video. Now a video is available in everyone's mobile, and you can easily have a video of this patient. So ask the patient's relative to have a video whenever he comes for next time. EG, I would say, is the most abused investigation. Unfortunately, whenever a patient, unconscious patient comes, and then you have a history of query seizures, you immediately ask for imaging and a EEG. Now what happens? You get a report on EEG. There is sharp background activity. There are some artifacts, and these are reported as abnormal EEG. But you have to look at the patient's clinical condition, the history. Then only you would be able to diagnose. Unfortunately, this is many times misinterpreted, and I would say don't look at the EEG to diagnose epilepsy. You will end up doing more harm to the patient rather than doing any good. So let us move at a particular condition. Let us look at the psychiatric disorders. It is always very important to diagnose a patient of psychogenic non-epileptic seizures, because this is the one which will really fool you in your medical practice. How do we evaluate? These psychogenic non-epileptic seizures are characterized by paroxysmal movements, sensations, and experiences that look almost similar to epilepsy, but they are not associated with epileptic discharge. They are most of the time associated with some psychological stressors in the family. Most of the time this usually starts in the adolescent group, not frequently seen in children and not frequently seen in old age person. So you have to look at various features. Let us go from one feature to another. Let us look at motor and non-motor signs. In psychogenic non-epileptic seizures, these are usually discontinuous. That is, they will happen, they will stop, they will again happen, they will stop. That is stop and go. They are irregular or asynchronous. There is side-to-side head movement, pelvic thrusting, opisthotonous posturing. They would have they would weep in between the episode. And these ictal behavior, you have to look at it, or rather you can even have history to have a proper diagnosis. Another test is, which we usually do, is when the patient comes with a history of seizure and becomes unconscious. What you do is you try to give a noxious stimulus. You lift the hand of the patient and drop it over the patient's face. If the patient is conscious, or if this is a pseudo seizure, he would try to avoid injury over his face. This is very commonly done in our practice. Then another thing is, if the progression is non-anatomical, it comes in one upper limb, then opposite side lower limb, and then it occurs in various places of the body at different times, which would make it a non-anatomical progression. And when the patient has a patient having generalized seizures, and if he is having a preserved awareness, this would go towards the pseudo-seizure. Duration, if the episode lasts for more than 5 minutes, that this is more likely to be a psychiatric disorder than a true seizure. Eye closure, this has already been discussed. In seizure, the eyes would be open, while in patients with pseudo seizures, the eyes would be tightly closed. And the patient, usually, when you try to open the eyes, the patient would resist to open the eyes. Tongue biting, again discuss. If it's a lateral tongue bite, then it is more towards epilepsy. If it is a tip, tongue bite is at the tip, then more likely that this could be a syncope. Post-ictal recovery, usually there is a post-ictal confusion in an epilepsy patient, while in the patients with pseudo seizures, they would start whispering, they would start muttering, and they would show motor response, or sometimes they can be absolutely normal after the episode. Let us look at this patient. She closes her eyes and tries to pretend And see, she doesn't fall, she protects herself while falling. Then these jerks. Then this abnormal movement, and in between she opens her eyes, looks at the camera and again closes her eyes. And see, again, this is not continuous event. This is an intermittent event. So this is a pseudo seizure. But when the patient's relative come to the OPD, झटके आ रहे थे, मुंह से झाग निकल रहा था, बेहोश हो गई. Immediately EEG, CT scan, and you start the patient on treatment. So need to have a video of such patients. Sometimes even suggestions, you give suggestions and they would start having this episode. This patient, we gave suggestion and he started moving the limb. Again, you may consider this as a focal seizure. And then it stops suddenly. Then, as I've said, side to side rolling. For family, it is a very big event, and for them they feel that this is really something very difficult. And unfortunately, they keep on having this in spite of various medications. And she becomes unconscious, and she even pretends having froth from the mouth. So this is also very common. मुंह से झाग आ गए. Then another patient, she comes with a history of tremors and some facial twitching, and this was initially diagnosed by our resident as a focal seizure. And if you, she was able to cooperate fully, and then we had the history where there were a lot of psychiatric problems and there was a quarrel in the family just before this episode. Hyperventilation, another patient. Unfortunately, what happens is during hyperventilation, there is CO2 wash off, and this may lead to some vasoconstriction, and this may lead to tetany, and sometimes even they can lead to syncope. And this sometimes may lead you to think that this could be a seizure episode rather than a pseudo seizure. So again, a video is very important. So this was an interesting patient. This was captured by the family members on mobile. You see this? He's having jerky movement, and intermittently he opens his eyes, trying to draw attention of the family members. Usually would occur in night when he was woken up from the sleep. So very good seizure mimicker. You all agree with this? No, you are all wrong. Because this patient had juvenile myoclonic epilepsy. So remember, any patient who gets up early in the morning and has this myoclonic jerks, unfortunately, why I am focusing on this case is because this patient was treated for psychiatric illness for 1.5 years. He was having these jerks. And now with, and medicine is very simple, just start sodium valproate. Unfortunately, sometimes there can be seizures with pseudo seizures. And this is very important, but many times the patient would have, when do you suspect that there could be pseudo seizures along with seizures? Whenever there is increase in the event, like a patient were having 4 episodes of seizures and now they have started getting 10 episodes per day. And then there is history of stressors, and then even the seizure pattern is different than what they used to get previously. Important is always have a video of these patients, or you can even consider video EEG in these patients. So this is about psychiatric disorders. Let's move on. Syncope. This is another stroke mimicker, and this is very important event, because whenever a patient comes with a history of unconsciousness, the first question which comes in our mind is whether this was a seizure episode or whether this is not a seizure. So syncope is an abrupt loss of consciousness due to an interruption in energy source of brain, which is usually because of sudden decrease in brain perfusion, which can come with hypotension or which can come with any cardiac event. It is always difficult to distinguish between seizure and syncope for the loss of consciousness. So, how do you try to distinguish? In clinical setting, if you see, seizure can occur anywhere, syncope can occur anywhere, so it won't help. Vasovagal syncope usually tend to occur when there is some strong emotion or painful stimulus, like drawing blood sample or even seeing the blood. Or I remember one of my friend following in the anatomy department. So it's or even with very trivial, small or some hot environment and patient may fall down. Reflex syncope also very common while passing urine or while coughing, the patient may have syncope. Sometimes with cardiac arrhythmias, patient may have syncope. Most of the time, syncope usually occurs in a standing position. If the patient is in lying down position and if you are considering syncope, then it could be a cardiac event. Warning symptoms in vasovagal syncope, prodrome or pre-syncope is a rule. Patient would have some tunneling of vision, there would be lightheadedness, there will be sweating, there will be warmth in the body, uneasy feeling, and sometimes they may have time to sit or lie down and they can avoid the syncope, but many times they may have episode. So always ask them about this lightheadedness and sweating, which is very common with syncope. If the patient has hallucinations, that would go more in favor of seizures. Pallor and diaphoresis is very strongly, thanda ho gaya, pasina aa gaya, would go more in favor of syncope. Lateral tongue biting, again, as I have said, would go in favor of seizure. This is what you see in a lateral tongue bite. Very classical of a seizure. Sometimes during syncope there could be some convulsive activity, and in one study it was seen that almost, if you go into details or if you are doing some test, then these patients would 50% of them would show some convulsive event. These convulsive events are usually like a tonic spasm of the limb or some myoclonic jerks, but these would last less than 20 seconds and usually patients become conscious immediately. Recovery of consciousness in syncope, recovery is very fast. In epilepsy, there would be post-ictal state. EEG would be less informative. During episode, you will have some slowing of the EEG. Always remember what we do in our lab is, this was introduced by Dr. Neeraj Bharti. We always have a ECG channel in our EEG. This ECG channel always helps you whether there were some arrhythmia during a epilepsy or during a seizure episode, and this can definitely help. What are the causes of syncope? Vasovagal syncope due to some stressful condition or a painful condition, cardiogenic syncope because of tachycardy episodes, or structural heart disease, aortic stenosis, where there could be low blood pressure, hyperventilation and hypercapnia. I have already discussed on this point. Orthostatic hypotension usually seen in elder population. It could be because of medicines or it could be because of the disease itself. Or reflex syncope like a cuff syncope or a micturition syncope, where there is vagal hypersensitivity. So how do you diagnose syncope? History taking and clinical features would go towards differentiating between syncope and seizures. CK, if there is a doubt, CK is creatinine kinase is raised in these patients. EG, as I have said, has a very low value. If it picks up epileptiform activity, then it would help. Arrhythmias and in patients with arrhythmia, you should always have a EEG. Tilt-table testing will precipitate vasovagal syncope and would help in knowing whether this was the vasovagal episode. This is what is a tilt table. The patient is monitored and then The table is lifted to 90 degree and you produce a strenuous environment where the patient may land up with hypotension or bradycardia, and this may help you in diagnosis. Next, we'll move to vascular condition. Common one is migraine. So sometimes it is really difficult to differentiate between migraine and epilepsy because both are paroxysmal events, both may have headache, both conditions may have gastrointestinal symptoms, they may have autonomic symptoms, and they can even have psychogenic features. Migraine visual aura is usually different than the epilepsy aura. In epilepsy, the episode lasts for very few minutes, maybe about a minute or less, or even 2 minutes. And usually they are highly colored, circular or spherical aura, and they move rapidly. In contrast, migrainous aura are gradually, they are more linear and geometric. There can be flashes of light on one corner, and they gradually build up over a period of several minutes, and it may last for even an hour or so. And usually it is followed by headache. So let us look at this. This is how a migraine aura may start. It would start with some blurred vision, and as the time goes, this gradually increases with some peripheral scintillations, and the aura is building up. The patient would gradually have diminution of vision or usually scotoma on one side. And after an aura, the patient would have or may have severe headache. Cerebrovascular diseases, we all know that these are negative symptoms. There is weakness. So many times it is very easy to diagnose an episode of stroke versus an epilepsy. But sometimes it may happen that you visit a place after the patient already had the seizure. So there is no eyewitness and patient only has weakness. And this could be Todd's palsy. So remember, you have to differentiate Todd's palsy from a real stroke. Next, paroxysmal movement disorder, very interesting. If we look at movement disorder, these are usually continuous event. So it is not very difficult to differentiate between a movement disorder and a seizure. But if movement disorder occurs in paroxysm, then sometimes it may be difficult, or sometimes if a seizure can continue, like a epilepsy, a partial is continue. If it continues, then this may appear like a focal tremor, or it may appear like a movement disorder. Paroxysmal dyskinesia, these are relatively rare conditions. In kinesogenic dyskinesia, when a patient usually occurs when there is some movement in the body and they would have some form of choreoathetotic movement or a dystonic movement, and which would last for less than a minute, and the patient would become normal. Usually occurs with movement. Non-kinesogenic, this doesn't occur with movement. Usually they have dystonic movements more than choreoathetosis, and they last for a longer time. The patient who had this, you can see this dystonic movement. This looks typically like a seizure episode. But here the patient is fully conscious. She has dystonia in all four limbs, more on the right side. So this is a non-kinesogenic because it is happening for a longer time and there was no stimulus, or did not occur with movement. Then another patient, this lady was recently admitted with us. You can see these dystonic movements and something more like a carpal spasm, which is basically a dystonia, which has lasted for a longer time. And this patient initially presented to us with features like Guillain-Barré flaccid paralysis, like Guillain-Barré syndrome. And over a period of next 3 to 4 days, she started having these features. This was her MRI, which showed a lesion, in upper cervical and brainstem. This was a patient who was NMO positive. So secondary non-kinesogenic dyskinesias can occur commonly in patients with some demyelinating disorders. Tics, again, otherwise very easy to diagnose. They are brief, sudden, rapid, intermittent movements, and they can be temporarily suppressed. But the patient will continuously get an urge to have this, but they can be suppressed. Look at this. He gets these jerky movements intermittently. These are tics. When you ask him to stop it, then he can do it for some time. But then that urge continues and then he would again have this. Oculogyric crisis, very commonly seen in our casualties. This is basically a upward eye movement and there can be associated spasmodic neck movement, also dystonic movement, which may last for a few seconds to hours together. Patient is fully conscious during this episode. So sometimes आँख ऊपर चली गई, गर्दन टेढ़ी हो गई, may lead you to diagnose this as a seizure episode, but this is not a seizure episode. This is a oculogyric crisis, and the commonest drug which we use that produces this oculogyric crisis is metoclopramide. There is a long list of drugs, many antipsychotics, antiemetics, antiepileptics, all this can produce, but common one is metoclopramide. Hemifacial spasm, there is involuntary synchronized movement on one side of the face which may appear like a focal seizure. How do you diagnose? First thing is the event which goes on for months together. Secondly, it starts from the eye, and another thing is it occurs only in facial nerve distribution. No other muscles are involved. This is the way you can diagnose. This is a patient having a spasm. These are usually clonic spasm, but sometimes there can be associated tonic spasm also. As you see this patient, the other one, this comes intermittently, so you may sometimes confuse it with a focal seizure. Initially it's a clonic spasm, and sometimes it may be severe enough to produce a clonic spasm. During this time, you look at the eye movements. If the eye movements are normal, then this is more likely to be a hemifacial spasm. Hemiplegismus, I think it is very easy to diagnose, but should know this. Unilateral, involuntary, sudden, violent movements, flinging movements. Usually, we may call it as a chorea occurring at the proximal joint. The flinging movements, arrhythmic, involving various joints. But since it is unilateral, sometimes you have to really consider other differentials. Then focal tremors. These are rhythmic movements, and since the patient also had facial deviation, so one may consider that whether this is a seizure episode which is coming. The other side, again the rhythmic movement. But what you are seeing on the right side is a focal seizure. It's not a tremor. So left side is a tremor, while right side, these are, if you see, they are not rhythmic episode. This is a rhythmic jerky movement. So that's how it has to be differentiated. And it is really sometimes difficult to differentiate between epilepsia, partialis continua, and focal tremors. Myoclonus, rapid, brief, jerky movements which can arise from cortex, subcortical region, spinal cord, or it could be even from the peripheral nerve, as you see in Isaac syndrome. See this old lady, see this myoclonic jerk. Another, this, she has multiple jerky movements. So this is classical myoclonic episode. Another patient comes with abnormal behavior, and you see her hand. He has jerky movements. So this is myoclonus. Since this is coming from the peripheral nerve, we would not take it as a seizure episode, and she has associated amyloid. So this is opsoclonus myoclonus syndrome, which you see with Morvan's syndrome. Hypnic jerks or sleep myoclonus. This is also very common. बच्चा सोते सोते jerk देता है and the parents are very much worried. These are usually jerks which occur in sleep. These are usually at the start of the sleep. The patient or a person, I would call them patient, person would have some jerky movements before just going to a sleep. So take home messages. Epilepsy is a paroxysmal disorder and a big list of mimickers. Out of 4, 1 would have non-epileptic episode. Detailed clinical history from patient and bystander is very important. Don't look towards EEG to diagnose epilepsy. Whenever in doubt, ask the patient to record it on mobile camera, and in uncertain cases, you go for a long-term video EEG monitoring. Thank you very much.
Thank you so much, sir.